All right. Good afternoon, folks, and welcome to the Palliative Care Friday Chalk Talks. Today we have a conversation about how functional status helps us with prognostication in our hospice and our outpatient palliative care settings. Our fabulous guest today is Tricia O'Connor, who is a specialist palliative care nurse at Clare Holland House Hospice in Canberra, Australia, where she's worked for over 15 years. Tricia has held various roles as a registered nurse and midwife across Australia and overseas, as well as in the tertiary education sector. She's a PhD candidate at Flinders University with a particular interest in the care needs of the unresponsive dying patient. So, Tricia, welcome from the future, and thank you for joining us on Saturday morning.
Thank you. Good to be here.
It's nice to know that the world will make it one more day. Living proof. So,
Indeed.
all right. So we start with the obvious. Can you give us just a high level summary of your cohort study that you published in Palliative Medicine from last year?
Sure, sure. I suppose going back, as you said earlier, I'm doing my PhD, and my interest was in that unresponsive dying person who's not able to express their own care needs. And then I went on to thinking, well, who are they and how long are they unresponsive for? Is it my imagination that they're unresponsive for a period of time? And so that's what started me on this whole journey, as well as the fact that in my day-to-day work, when I'm caring for somebody who is in those last days and hours of life, and we're so often asked that how long question by families and loved ones. They want to know whether family from overseas or interstate have time to get there. They want to know whether they should be staying overnight. They're exhausted. They want to know how long more. And I realized that we actually didn't have an answer to that. I was saying we don't know. I know that there's been a lot of work done in this field by, David Huey and Murray and Barrera, etc.
Yeah.
But often that was, solely either cancer patients or looking at a much bigger picture rather than those people who were already unresponsive at the very end of their life. And so at Clare Holland, we were already gathering data on our patient information management system. So I figured we had all that data already. And our aim then was to determine how long dying patients in our palliative care service were unresponsive prior to death. I also wondered whether, there was a difference in that period with regards to age, gender, diagnosis, whether they had cancer, non-cancer, etc. So we thought we would include that as well. And that routinely gathered data. We were using the Australian modified Karnofsky status, and that obtained a kind of a performance score. So I'll call it the AKPS for short, because Australian Modified Karnofsky score is a bit long. So this was a clinically rated assessment that measured the patient's performance score across, dimensions like activity, work, self-care. And I guess for people who don't know about the Karnofsky score, it's say 100 would be you and I, where we're here, we're able to work, we're able to function, we're able to carry out our normal activities. And then if we go down to the AKPS 20, this would be somebody who would be bedbound and they'd need lots of assistance and care. But what I was specifically looking at was the AKPS 10, which is when the person is comatose or barely rousable. And so that's that very unresponsive, very vulnerable patient, and that's who we were looking at. So our service has three different arms. There's the inpatient hospice, and then there's those who are cared for in the community. And then we have an in-reach service to 28 different residential aged care facilities or nursing homes locally. And so all of those people that we gathered this data on, they were over 18 years of age, so no pediatrics. And we ended up with, after various exclusions for people who didn't have consistent scores, etc., we ended up with 786 participants across a 10-month period. And then they had to have an AKPS score of 10, that be comatose or unresponsive for longer than 24 hours, because we didn't want to be including people that maybe had medications or, just really having a really good sleep. And then our results, we found that nearly half of those who died, 49%, were in fact comatose or barely rousable for a period longer than 24 hours. And that then when we looked at the average length of time, or the number of days to death, once they became AKPS 10, that it was 2.1 days. And this was regardless of their age, regardless of their diagnosis, once they were unresponsive and in that AKPS 10 stage. So basically, we had that answer, 2.1 days.
Mm.
But then, I guess, and the other flip side of that is there was also just over 50% of people who weren't unresponsive prior to death.
Mm-hmm. Helpful when it's present, but not very helpful when it's not present.
Yes. Yes.
Which is pretty consistent with most of the other physical exam signs. Highly predictive when they're present, but not all that helpful when they're not.
Yes. But at least now we can say
Yeah.
we've looked at it.
Yeah. And,
no, go ahead, sorry.
and I appreciate that it wasn't just cancer patients, right? So many of those studies that you just referenced were done exclusively in oncology patients, and this was not. And it that helps us to feel more confident with things outside of oncology.
And in fact, we found that we had only 45% of our participants actually had a cancer diagnosis. And I think that might be because we had a huge percentage of, we had more than a third of our participants were actually from residential aged care. And a lot of those people, although they might have been living with cancer, they were actually dying from perhaps frailty, multi-organ failure, etc. Yeah.
Perfect. All right, my favorite part. So the patterns in figure two. I'd love to get your observations about what stands out in this picture. What would you like to share with us?
Um, I think these are great panels as well. You wouldn't want to be colorblind, but yeah. So these panels are of the 786 patients, and if you're looking at the x-axis, that's over 200 days, so that's 6.5 months period. And then on the y-axis, we have the AKPS score down the side. And clearly, it's only starting at 80 because anybody who's above that was doing really well and didn't need to see specialist palliative care. So if we look at that first panel there, which is the cancer versus non-cancer, like I say, only 45% of our total cohort had a cancer diagnosis, and lots of people have written about end of life and in cancer patients. But if we look at this, we can see that decline that kind of starts 6 to 8 weeks out. And then approximately 20 days from death, you can see that rapid decline. But it's a rapid decline for both cancer and non-cancer. So that there's like a similar probability, really, of not surviving. And if we look at the non-cancer, we can see that they have a much lower Karnofsky score. So they're sitting there around that 30 to 50, and a 30 to 50 score is when the person is needing considerable assistance, right down to 30, where it is almost completely bedfast. So those people who have those chronic non-cancer conditions are, less able for a long time. Whereas often those, dying from cancer are often much fitter. And then if we go on to panel B, which is, again, a color blindness person's nightmare. um, and you can see that those with, say, for example, those with cardiovascular disease, they're in there between AKPS 40 and 30, where they're needing lots of care and requiring, they're much more sedentary, being in bed for more than 50% of the time. And that's, about 110 days out prior to death, which is about 4 months. And I guess we can see that in our clinical practice too. In comparison with those who have a cancer diagnosis, they have a much higher functionability for much, much longer. And equally, if you can see that the black square, those are those with Alzheimer's disease, and it's that consistent kind of lower function for a long time. But regardless, they all then seem to have this rapid decline, regardless of diagnosis. Again, it's between the 20 and 30 days prior to death. And then there's that tipping point where they all seem to just kind of, I don't know, fall off the cliff, really. And then if we go on to panel C, on the other hand, you can see that those living in nursing homes, they already have a very low functional status, with a large number of them scoring between AKPS 30 and 20. So in other words, a lot of them are needing lots of care or, totally bedbound from much earlier on, even from, 4 months out again. So I think that's a really interesting thing. But again, they all come to that for people who are in nursing homes. Really, it's in the kind of, they're so low on the AKPS score that you can see that they're very close to death in that AKPS 20. And then you can see that decline along with everybody else in the hospice as well as in the community. And then in panel D is really all about age, I guess. And a lot of our younger cohorts, so, had a cancer diagnosis, and over 38% of our people were cared for in nursing homes. So the ones in the nursing homes were a very elderly, frail population. And then you add those in the community and in the hospice who were already elderly as well. So we actually had 57% of participants who were over 80 years of age. Whereas most of those aged between 18 and 60, like I say, they had a cancer diagnosis and were often really fairly physically robust to begin with. And as you can see here in panel D, there's still that rapid decline 20 to 30 days out. And if you can look carefully, though, you can see those, under 60, they stay relatively well for a little longer. But then again, there's that rapid decline.
I think what worries me most about looking at panel D is that patient you described earlier, where your family isn't living nearby and they want to know, or it's time to travel and say goodbye. You have a much narrower window for these younger patients who are able to hold on longer until you start to see them falling off the cliff.
Yeah. Yeah.
Certainly
Yeah,
challenging.
I agree. I think we've all seen that very rapid decline in young people with little warning. And I guess this research allows those who are perhaps new to caring for young people to visualize how rapid that decline can occur. And so be aware and bear that in mind when they're attempting prognostication and when they're talking to families, and actually say to them, really, it can be very quick. We might have very, very little notice. So, to be conscious and to be aware of that, and let families know that can be the case.
Hmm. The
It,
only
it's it, it, it's tough, yes.
Yeah. The only other point I wanted to make before we move on beyond the panels is for panel C, if it seems to me that earlier on, many illnesses have their own trajectories, their own patterns. And yet when we get into those final weeks, everything seems to converge and everything seems to follow a similar pattern.
Yes.
And one thing that I've always struggled with, because again, referencing those same studies on physical exam that you mentioned earlier from MD Anderson, again, so many of them are about just cancer. Do they extrapolate? And clinically, my experience is that when people are in those final weeks or month of life, it does extrapolate because everybody sort of converges into that same funneled pattern towards the end.
And that was really interesting because you have these ideas in your head, but you don't know whether it actually is true or not. When I was thinking about this, prior to getting these answers,
Yeah,
um, I had the notion that it was the length of time that people who are unresponsive was closer to 3 days rather than 2 days. And I had thought that people who were in frail elderly, that they may have been in that AKPS 10 for a little bit longer. Whereas in fact, those graphs are very much showing that, everybody converging. Yeah. They make very interesting looking just on their own right.
sure.
Yeah.
Well, that's a perfect segue to our next question, which is about outliers and humility. So you shared the data already, right? We've got the average. I'm going to look at my notes, make sure I got this right. Yeah, the average number of days until death after a new KPS of 10, 2.1. The likelihood of death after a new KPS of 10 within 4 days is 84%, and that only 1.8% of patients lived more than a week, with the longest outlier being 18 days. So your team tried to examine these outliers and try to find some patterns. No clear patterns as far as I could tell. Some time has passed, right? You published this paper a year ago, and probably you had been working on it a year or two before even that. Any any new obvious patterns that stand out to you, or do we just need a really healthy dose of humility in our prognostication? Or both?
Yes, healthy dose of humility is always a good thing when you're talking about prognostication, really. So yeah, we did read through all those notes, and again, you have these preconceived ideas, and a lot of textbooks say that people are hanging on because they're waiting for somebody to visit. There's some unresolved issues, etc. And again, I thought that would be really interesting to see whether those outliers and people that did live on for, quite a long time, 18 days, to see whether there was any reason that they were living on that long. And we didn't actually find any reason, which to me was a little bit, I guess, not surprising, but a little bit disappointing because, we want to have answers. We want to
Yeah,
close off all
yeah,
these
yeah,
things.
yeah, yeah.
Um, and so, no, there didn't seem to be any reason. And I think that's something that's really important now in my practice, to remember that, and to say to people that it is possible. It is possible. And that, have that, as you say, that take home point of a healthy dose of humility is a really good thing when we're trying to prognosticate. Um, and so I guess in my own day-to-day practice, and things that I have changed since then, is to actually say, yes, there is now work. It has been done, And in fact, even though it's been done, we still don't really know that the average person is 2 days, but that there are many more who will do it in their own time. And so, I do say to families when I'm talking to them that, you know, your loved one, I bet she was, she was unique in her own life and she'll be unique in her own dying.
Hmm.
So, and people will then often talk about, yeah, yeah, she was really stubborn. So, yes, I guess she'll do it in her own time. And it brings that conversation in where it's okay not to actually know, but we're saying and we're putting it out there that we don't know. People will say, yep, once he makes up his mind, that's it, he'll probably go. And I guess in many ways, it's a bit like babies. We have an expected date of delivery, and they come in their own good time too. And I guess we will leave this world in our own good time as well.
Hmm. That's beautiful. Yeah, you kind of answered my next question. I mean,
Oh,
it's no, and thank you because I mean, it's not to be paralyzed by the uncertainty and just say, I don't know. We don't know. But it is an and statement, right? It's here is what we do know and appreciate that we don't have that perfect crystal ball, and I cannot tell you exactly what it is, but I can tell you what is most likely, and we start with that and we work from there and we do the best we can. Absolutely.
yeah, and I think it also highlights to people that uniqueness of us all
Hmm.
and our individuality and our personality is coming out right to the very end.
Yeah. All right. You pointed out in your results that this may not necessarily be applicable to patients outside of the specialty of palliative care or hospice. Can you tell us a little bit more about some of your skepticism and why that may be true?
Yeah, look, as a specialist palliative care service, we see people who've got, complex symptoms that often need, some kind of intervention, whether it's psychosocial or whether it's physical, requiring medications such as opioids. But really, the cohort of people that we see require some kind of interventions. And yet, out there, many, many people die very peacefully without any distressing symptoms. And our research didn't actually look at that population at all. I think it would be really good to look at a population outside of a specialist palliative care, but I guess it would be very hard to get that kind of data. And equally, we didn't marry up our the medications that people were receiving at end of life. So the level of opioids whether people were on syringe drives or whatever,
Hmm.
we weren't able to do that because our electronic medication system didn't marry up with the other data. So I think that'd be great research to add to this, in fact, if somebody out there was keen to do it, to see whether, medications influence survival at that very end stage of life.
Sure. All right, our last question for you. So, I mean, you and I started talking about this maybe 6 months ago, and since then, you have
Yeah.
just a few weeks ago published a follow-up piece on this. What can you tell us about it?
Yeah, like most good research one question generates many more.
Mhm.
And we did have, 5 more years worth of data, but it was only across two arms of the service. And we thought we should look at and ask the same questions. But equally, we're looking now at this person who is unresponsive and dying, and they're no longer able to make decisions for themselves. So we thought, well, would the AKPS score be able to tell us at what point they lose that capacity by becoming an AKPS 10, so that we can say to people, you've got this window period where we can get this person to tell us what their wishes are, for family to visit, to say their goodbyes, um, and to really know that we're providing the care that they want at that very end stage of life. So we use that 5 years worth of data. Across, there was only two arms of the service, the inpatient unit and those that were cared for in the community. And we repeated that study, and we had, 2,500 people this time, and we found exactly the same trends. A little over half were comatose or unrousable prior to death for longer than 24 hours, and again with that same average of 2 days. And I guess the only real difference was instead of 1.8% outliers, we actually had 2% outliers, which really wasn't that difference. However, when we were looking at the AKPS scores, we looked at people when they moved from an AKPS 30 to an AKPS 20, and that first movement into AKPS 20 until they came to an AKPS 10, because that would be that window, so that we would be able to help people to, like I said earlier, say their goodbyes, make their decisions around care. And yeah, that was really interesting. That identified on average that there was 24 days between moving from the 20 to the 10. So that was a very interesting study to follow on from the first one. It kind of reassured us the figures from the first study, but then looked further.
Mm-hmm. I I've read some of the other literature out there about a KPS of 20. And it's interesting when if I go back and take a look at your picture of the different illnesses, the people with dementia, a lot of them have been sitting at 20 for so long. And I imagine that while that is certainly an average, there definitely are illnesses out there that are outliers that need to be used with caution that might be sitting at a KPS of 20 or 30 for quite some time.
Absolutely, and particularly, like as you say, those
Hmm.
with Alzheimer's or some other form of dementia,
Yeah.
and equally those with that chronic non-cancer diagnosis. That yeah, so a lot of that, absolutely, a bit like all research. You take it, you look at it, you take what you can from it, but equally that good dose of humility, like you
I
said
like it.
earlier on.
Yeah. All right. Well, before we send you on our way, any other parting thoughts or pieces of wisdom for us?
Um, not really. Like I say, I think bear in mind that that very end of life is a very difficult time for families, and being able to say, I think as a clinician, we don't know is okay. That we have done research, it doesn't give all the answers, and I think people are very accepting of that.
Yeah, I've certainly been looked like an idiot in the past when I have been so
We all
certain.
have.
Yeah, yeah, yeah. We all have. We all have. I
We
appreciate it.
all have.
Thank
We
you,
all have.
Tricia. It was lovely. Thank you for joining us on your Saturday morning.
It was great. It was great to be talking to you in chilly other side of the world, knowing that we've got some nice sunshine out there today.
All right. Take care, Tricia.
You too. Thank you very much. See you, Marty. Bye.